Hey folks, Professor Finn here, and today we're going to be looking at Chapter 11 in your Embalming History, Theory, and Practice by Sharon Gee-Mascarello. Right about this time, I know we've had a couple of pictures showing some of the graphics in the textbook. Just be aware that going forward, we're going to have more and more chapters showing pictures of deceased and stuff like that. Hence, there may be some triggering material in here for some individuals. And if you find that it is triggering and you are in a course of study at a funeral service, accredited funeral service program, you might want to rethink that course of study. Just saying. This is stuff you're going to see on a day in, day out basis. So let's go ahead and get the screen shared and start talking about preparation of the body prior to arterial injection. Blink. So first and foremost, most important thing, follow your state's regulations when it comes to things like securing authorization. Under the FTC funeral rule, the only thing that you need in order to proceed with an embalming is oral authorization. There are some states that require written authorization before you can proceed. Know what the laws are in your jurisdiction. Obey all the laws in your jurisdiction. Now, permission to embalm is obtained from the legally authorized person. Sometimes that is the next of kin, sometimes it is somebody else. So the term that I am going to use for any authorizing person is either legally authorized person or the authorizing agent. Funeral directors do not determine who the authorizing agent is from a legal sense. A funeral director has to follow the law of the state in which they are practicing and are licensed to practice. So if there is a dispute as to who has the authority to do something, send them to their lawyers, let them figure it out. You, as the funeral director, do not get to say with certainty who it is that gets to do something. That is a function of law. Let the judge say who is in charge. The best practice is to obtain written documentation for the authorization for permanent record under the FTC funeral rule. When you meet with the family to make the arrangements, you must obtain the written permission to embalm at that time. So, any family that is going to authorize embalming, you will get it in writing because that is the federal law. The federal law just states that you can obtain verbal permission to begin and then obtain written permission later. Embalming is separated into three phases, which we've described before: the pre-arterial injection, the period of injection, and post-arterial injection. So the before, the during, and the after. Included within each phase are the procedures routinely performed during that time period. Now, one of the important things to recognize here is just about anything that we are doing can be done during any one of the periods. When we are talking about these duties, we are talking about when these duties occur in the logical textbook sense of how we should be doing it. Sometimes when we run into complications, we may do things out of sequence. So for instance, something that might be commonly done in the prior to arterial injection, we may be doing during injection because of that specific circumstance. So it is important for you to know when something is normally done and then know what the exceptions are, or what the causes to those exceptions are, and where they should be done after that. So evaluation of the body is ongoing during each of these time periods, and this goes back to Chapter 10's embalming analysis. What do you see? What do you do to fix that? Try that. Did it work? Yes or no? And then right back to the beginning. What do you see? Observation and evaluation, the proposed method of treatment, the implementation of the treatment, and then the observation and evaluation of results. Now, effective embalming is achieved when distribution or flowing of the preservative solution through the vasculature body allows it to diffuse, which passes from the capillaries to the tissue spaces, and then that embalming chemical is retained. So you get effective embalming when you can get the fluid throughout the body, when that fluid diffuses into the tissue spaces, and then there is a sufficient quantity injected to maintain that process over time. The embalming process actually begins when the deceased is transferred from the mortuary cot to the preparation table. The moral of this story is the process begins the very moment you are transferring to the table. When you are doing that, if you are lucky enough to have any mechanical assistive devices, you should be using them. Center the body on the table and then topically disinfect clothing, sheeting, body bags, whatever it is. Everything should get sprayed. This helps reduce the aerosolization of microorganisms and other particulates and is also a best practice. So, standing at the side of the embalming table, gently roll the body towards you, okay? Roll the body towards you, pull the body towards you by placing hands on the shoulder, hands on the hip. Where the hips go, everything goes. So pull the body towards you and then start tucking things underneath the body. Roll the body back, go to the opposite side of the table. Once again, pull the body towards you, and then you can pull the materials out for disposal. Clothing should be removed without cutting whenever possible. This is not your clothing. This is not your clothing. You should not be cutting it, and you should not be throwing it away without permission. And you might say, well, Professor Finn, it's contaminated. And my response is, that doesn't matter unless local health or Center for Disease Control guidelines say that you must dispose of something without returning it to the family. So you must have legal authorization to do that from the state. You might say, well, Professor Finn, that's garbage. You don't know what you're talking about. Well, how many times do people go to a law enforcement agency, get the personal property of a decedent back from them, and the law enforcement agency has scrubbed everything down, laundered that material to make sure that it is not biologically contaminated before it is given back to the legal next of kin? And the answer is just about never. So there is no magic between the Leo agency and ourselves. It is not our property. We must return that property to the family or to the legally authorized person. So if you've just been taking personal property and disposing of that, the moment that someone doesn't like that you did that, you have incurred significant liability. And don't be surprised if that $20 clearance pair of jeans from Walmart just turned into Versace designer jeans from Nordstrom's. Inventory and document all personal effects. Affix an identification tag or label to the items and securely store them until returned to the family or authorized party. Do not dispose of any items unless you are directed to do so. And the best practice is to document in writing the directive for disposition of the personal effects. Glasses, jewelry, watches, and religious articles should be removed during embalming. We use some pretty nasty chemicals. They stain things, they oxidize things, they can even melt things. So it is best that you keep anything off the body during the preservation process and return it afterwards. During body transfer, the best practice is to pull rather than push the body. So if you are having to move a body from the cot or the stretcher over to the table yourself, you should not sit there and push the body onto the table. You should grab the body and pull it towards yourself onto the table. And it gives you a sequence by which to do this. Again, the most important part, pull the legs and buttocks onto the table first, and pull the trunk and shoulders. Professor Finn's going to say it again in case you missed it the first time. Where the hips go, the rest of the body goes with it. So if you can get the hips onto the table, the rest of the body will come naturally after that. If you have been using something such as a backboard, you will pull the board over to the table with you and then remove the board like you're removing a body bag or something else. Pull the body up onto you, take the slide board out or have an assistant do that, and then roll the body back onto the table. So first and foremost, know your limits. Don't try to impress anyone. It's not worth the hassle. And it's not worth the bad back. Lift from a lower surface to a higher surface and transfer surfaces that are level and abut one another. Ideally, you will want the surface where the body is slightly higher than the surface it is transferring to. That way, as you pull the body over, gravity will help you and the body will slide right onto the table. Now, another bit of practical advice. If you are moving a body that has a lot of skin showing, in other words, missing a shirt, only wearing a pair of shorts, etc., one thing you'll see experienced embalmers do is they may take the table water and wet the table. And what I would do is I would take the disinfectant spray and I would spray the table before moving the body. And the reason is dry skin sticks to stainless steel. So if I put a surface of disinfectant onto the table and then I move a body over that has a lot of exposed skin, it will slide onto the table and allow for easier positioning. After the sheeting or clothing has been removed and the body is placed in the center of the table, a modesty cloth should be placed to cover genitalia or torso in women. All body surfaces and orifices are treated with a topical disinfectant. The disinfectant should be sprayed onto the body with particular attention to all body orifices. Spray into the nose, into the ears, the genitalia, every place, the mouth, and follow manufacturer's instructions as to surface contact time. If it says spray the body and let sit for 5 minutes, spray the body and let it sit for 5 minutes while you do your analysis. This will give time for the spray to kill the microorganisms. A droplet type spray is preferred over pressurized sprays, which lose too much of the disinfectant to the surrounding air and can be inhaled by the embalmer. Disinfection of the body should also include the destruction of body lice or mites. If scabies is suspected, a commercial pediculicide should be applied to the skin and hair of the deceased. The embalmer should carefully handle these bodies so that the insects do not infest the skin of the embalmer. Carefully check for fly eggs or maggots, especially in the months of summer or in warm climates. Fly eggs appear as yellowish clusters in the corners of eyes, nostrils, or ears, or within the mouth. If present, these eggs can develop into the eating larval stage known as maggots in 24 hours. Great care should be taken to remove all eggs. If the larval stage has begun, a mortuary larvicide can be used. Maggots also feed upon embalmed tissues. Maggots also feed upon embalmed tissues, so it is very important to remove and destroy them. To prevent flies from depositing eggs, keep the body covered, keep the windows closed, keep your doors shut. Nostrils can be packed in the months of summer, and small pieces of cotton can be placed in the nostrils, extending outside when the body is left in the preparation room or is shipped. Now, in the United States, we typically do not leave cotton visible in the nostrils. In some Latin American countries, that is a very common thing to see in their death rituals. When you are placing cotton into the nostrils, take care to observe the natural contour of the nose. If the cotton is pushing things out and you inject a preservative solution, don't be surprised if that preservative solution keeps the nose in that awkward position with the cotton. So you want to make sure that even when you are packing, that you're maintaining a natural look of the face. In the months of summer, some funeral homes make a habit of covering the face of the body at night. Outside windows and doors of the prep room should be screened. Insecticides should be used if flies are present in the prep room. Once fly eggs develop into the larval stage, it becomes nearly impossible to control. The entire body is thoroughly bathed with warm water and germicidal soap. Special attention is given to the viewable areas, the face and hands. And obviously, these areas must be free of dirt and body oils for good cosmetic application after embalming. Scaling skin between the fingers and facial creases and around the hairline can be removed with a solvent. This is typically a dry wash or an acetone. Massage cream applied to these areas helps to cleanse facial pores. After thorough washing and rinsing, the body should be dried with toweling. Flexing and rotating the limbs while bathing helps to relieve rigor mortis. When bleach or sodium hypochlorite is used in the solution for washing the body, it is important that the chemical be washed away with water before any contact is made with formaldehyde. Sodium hypochlorite and formaldehyde combined in large amounts can produce a potentially dangerous situation. It is a toxic product. Fingernails should be scrubbed with a nail brush to remove debris beneath the nails, or an instrument may be used to gently release material from under the nails. A solvent is used to remove surface discoloration, such as grease or tobacco stains. Nail polish is removed with polish remover or acetone. It is beneficial to leave polish on one fingernail so you can match the color later. So you can clean all the nails off, leave one so you have an idea of what the color is, and then once you've gotten the right color, now you can finish cleaning all the nails off and you're good to go. Nails are trimmed and shaped after cleaning. Hair is washed at the beginning of embalming to remove bacteria, dirt, oils, and odors from the hair. The hair can be washed a second time to remove any blood or chemical odors that remain after the embalming procedure. It is quite common to rinse the hair, to do that. You'll use shampoo and conditioner maybe the first time. If you only do one rinsing, what I would do is I would use the germicidal soap for the initial bathing and combing out of the hair, and then towards the end of the procedure, that's when I would apply the shampoo and the conditioner, so that I am using something to get rid of as much garbage, dirt, and nastiness as possible. And then after that, I am applying general hair care products for best presentation. The following are best practices for hair care. Consult with the authorizing party before removing braids. Comb through hair prior to shampooing. Wash the hair with warm water and germicidal soap or shampoo. Use cool water to remove dried blood from the hair. Use hair conditioner to detangle long hair and aid in styling. Apply a dry wash solvent to remove dandruff. Comb or brush hair back from the forehead. Retain natural curls by kneading the hair with a towel after combing. Avoid overbrushing hair when it is falling out, and towel dry and or blow dry the hair. Facial hair is removed according to the wishes of the family and after permission has been obtained. When in doubt, you do not shave. When in doubt, you do not shave. It is more difficult to do later, but it is safer to shave only after you have authorization. When instructions are not available prior to embalming, shaving can occur after embalming. Shaving is more difficult at that time. The tissues are less flexible, but doing a hair restoration is even more time-consuming and annoying. Shaving creates a smooth skin for the application of cosmetics. Cosmetics will stick to stubble hair, making it more noticeable and creating an unpleasant appearance. Therapeutic drugs can cause facial and forehead hair growth on individuals who never had facial hair. This type of facial hair is easily removed by lightly passing a razor over the facial tissues. After shaving the forehead, apply massage cream. Note the following points during shaving of the face. Use a good, sharp blade. More than one blade may be needed to shave dense growth. Apply warm water to the face with a washcloth first. Use shaving cream to lather the face. When there is doubt about the length of sideburns, mustache, or beard, consult the family. If they cannot be reached, these areas can also be shaved after arterial embalming. When using a new blade, it is wise to begin shaving on the non-visible side of the face, the left side of the face, or in the neck area to slightly dull the blade. I've also seen professional embalmers maybe shave a little bit on the legs or high on the arms where things will not be visible. That way you do not have a super dangerous razor and nick something by accident. I've even seen embalmers take it and shave their own arm hair or something like that just to deaden it down. Not saying it's right, I'm saying that's what I've seen. Shave in the direction of hair growth. Bodies vary, and sometimes shaving must be directed against or perpendicular to the growth. Moral of the story, trim it out before you start going against the grain. Trim it out, get as much gone as possible, and then start going against the grain. Use small, short, repeated strokes over an area to achieve the closest shave. An area can be shaved repeatedly from one or several different directions. Clean your razor frequently with warm water. Some people will keep something like a small Tupperware tub, a Cool Whip tub, something like that, fill it with hot water, and then they will use that table side in order to clean the razor. Some people will take it and spray it with a hose. Me personally, I like having a container that I can swish the razor in and knock out all the stuff, and then put it under table water if I need to try to dislodge something particularly stubborn. Try to shave an area without lifting the razor off the face. Apply pressure on the razor and slide the razor over the area being shaved. Use cotton or a washcloth to pull the skin taut for shaving. This is helpful in shaving beneath the mandible and the upper neck area. After shaving, wash the face with a washcloth and warm water. A thin layer of massage cream may be applied, and trim hair from nostrils and ears at this time. So we are in the pre-embalming period. Razor abrasions occur from nicking the epithelial tissues. Application of massage cream helps to prevent the area from dehydrating and darkening. During arterial injection, arterial solution may leak through these nicked areas. It may be necessary to apply wax over these areas after cosmetics have been applied. This prevents further drying. What you are concerned about here, folks, is when you have a nick and it is leaking arterial fluid, the active dyes will stain the surface skin. So then you're going to have to apply cosmetic to hide that. It is really important to take some massage cream and create a barrier layer so that if something does leak, it will stain the massage cream and it will not stain the skin underneath. So it makes very good sense to add massage cream after shaving on all cases so that even should something leak, you have that protective area. That is also something that protects against stomach purge, which has acid in it. So it is very common that if you are anticipating stomach purge, you apply a layer of massage cream around the mouth and the nose so that should some purge happens, that it will not be damaging the skin. If facial hair must be shaved after arterial injection, lather the face with shaving cream and allow the lather to remain several minutes. Use a new razor blade. And I am telling you, it's probably a good idea to break out a cheap pair of clippers. Go buy some at, say, a Home Goods or a Burlington or a Ross, Dress for Less, Walmart. Just a cheap, inexpensive clipper. Shave off what hair you can and then use the razor to do some finer trimming. To avoid nicking the tissue, shave in small areas and keep applying lather to the area being shaved. When completed, apply a thin film of massage cream. An electric razor over a dry face is also effective. Start with the electric razor and then work your way into the other stuff. I personally prefer using a high-quality shave soap versus Barbasol or anything in a can. I have found that to be a superior product in the prep room, and the small amount of money you will pay for shave soap, it will last a pretty long time. To shave thick or long facial growth, first trim the hair to a manageable length with barber shears or hair clippers, and then follow with a razor directed from the cheek downward over the face. Heavy growth may necessitate the use of several blades. After the body has been shaved, massage cream may be applied. A minimal amount is adequate to protect the skin. See, a lot of people apply massage cream like they're applying cream cheese to a bagel. You want the skin to look wet, okay? That's especially true for body storage. You want the skin to look wet. You can reapply massage cream as necessary. Now, when you are shaving, and it says use of several blades, there are many different types of razors out there. Some people use very inexpensive disposable Bic razors, the little blue ones or the white ones with the yellow tips, the orange tips. Everyone has their way of doing it. I think a good double-edged safety razor, an old grandpa razor from basically World War II, is outstanding for that. Blades are extraordinarily inexpensive, and if you treat the razor right, it will literally outlast the embalmer. So think about what you're doing. Practice with the razors that you have. Find the one that you like to use and use that one. Massage cream has several advantages. Protects the face and hands from surface dehydration, protects broken skin areas such as razor abrasions from dehydrating and darkening, acts as a lubricant to relieve rigor mortis, it acts as a skin cleanser, and protects the face from acidic purge, and provides a base for cream cosmetics. The embalmer manipulates the limbs of the decedent while removing clothing and bathing to relieve rigor mortis. The stiffened muscles caused by rigor prevent proper body positioning during embalming. Bending, relaxing, flexing, And massaging limbs to relieve rigor can damage capillaries, which leads to tissue swelling during arterial injection. So the other day I saw something from an embalmer saying, deep tissue massage for use in prep. Now, I didn't get to attend the workshop, but the concern there is if you are getting hard and heavy into the body with massage, you may be rupturing capillaries. And if you're rupturing capillaries, you're going to get swelling that you do not need. So, gentle and firm massage is probably best. Avoid excessive exercise of the muscles in relieving rigor mortis. Relieving the rigor also relieves extravascular resistance upon the circulatory system. Relief of the rigor results in better arterial solution distribution and also better drainage. A routine procedure is listed in this chapter. It's been discussed previously, so we're not going to cover it all over again. So when positioning the body, the objective is to create a comfortable and restful appearance. Preservative arterial solution will firm muscle tissues in the position they are set by the embalmer. So what was the old saying? Set it and forget it. That's kind of what we want. Set it and forget it. It may not be possible to reposition the body afterwards, especially if you're using a hard and fast firming solution. The positioning of the body as it rests on the embalming table should be the approximate positioning of the body while casketed for most comfort. 3 positioning levels are desired. The highest level is the head. The middle level is the chest. The lowest level is the abdomen. And the reason is the body is going to be sitting on a pillow. The chest should be up. And then the legs slightly depressed. Anything that is going to migrate, any liquid that will move, will go away from the head and into dependent areas of the body where it will not be seen more than likely. The body should be placed in a supine position in the center of the embalming table with the head located near the top of the table. This position allows adequate room for positioning devices for the head and arms. The carotid vessels can then be raised by the embalmer standing at the head of the table. Rest the buttocks on the table or upon a body bridge to establish the abdominal level. Next, place a body bridge under the shoulders. Elevation of the head and shoulders helps to promote drainage from the head and neck areas. A variety of positioning devices can be used for shoulder supports. The chest and the head are also elevated to prevent blood that remains in the heart after embalming from gravitating into the neck and facial tissues and graying these tissues. This discoloration, the reaction of formaldehyde with blood, is known as formaldehyde gray or embalmer's gray. Now, in the previous chapter we'd said, hey, under refrigeration, you may have false signs of preservation. Blood can get trapped in the capillaries, or hemolysis can occur, and some of that blood can migrate into the tissues, and it will look like the skin is, or the tissue is embalmed. And when the preservative finally reacts, that tissue starts to turn gray because of the fact that there might not be enough dye in there. That is embalmer's gray. The shoulders are elevated to assist drainage, keep water from contacting the back and shoulders, prevent gravitation of blood into facial tissues after embalming, and assist in drying the body by allowing air to pass beneath the body. Assist in draining edema from the facial and neck tissues, and position the head and chest higher than the abdomen. The head is adjusted on the headrest after the shoulders have been elevated. If the shoulders have to be elevated greatly, the headrest will need additional elevation. Place a folded towel between the head and the headrest to elevate the head to the desired position. I've seen all sorts of ways to get the head where you need it. Combination of essentially towels, sheeting, combination of towels and empty fluid bottles sometimes works well if you have a really weird elevation. There are lots of things that you can use in the prep room to get the head where you need it for preservation purposes. The head can be tilted slightly to the right, approximately 15 degrees for viewing, or the head may not be tilted at all. That depends on your local community and customs. So 15 degrees or nothing, straight ahead. Know what it is in the jurisdiction that you are practicing. At the start of arterial injection, the hands can be placed on the sides of the body or lowered over the sides of the table. This forces the blood in the veins of the arms to gravitate into the capillaries of the hands and expand the capillaries. Once the embalmer establishes fluid distribution into the arms and hands, the hands can be positioned upon the abdomen. placement of the hands upon a towel will prevent them from slipping. So if you have something there that has any sort of texture, that will create just enough resistance that the hands won't move with any luck. Elbows should be elevated from the embalming table with the head or an arm positioning device. Raising the elbows prevents interference with blood drainage along the sides of the table. Keep the elbows close to the sides of the body. Cultural and religious custom may dictate the positioning of the hands. Typically, it is hands kind of cupped over each other. Be very sensitive. This has hit me a couple times throughout my career. Be very sensitive to whether a person is right or left-handed. There is a retired embalmer, used to be a chemical representative for the Dodge Chemical Company. His name is Jay Rhodes. Jay is a longtime associate and friend. And one thing that he did that was really nice is he would position hands like this. So usually hands are cupped like this, with the wedding ring showing if one is present. Jay always positioned his hands like this. And the brilliant thing about positioning hands like this is it allows for the showing of anything on any of the fingers. So when someone is right or left-handed, that will determine what wrist the watch is worn on. So what you want to do is make sure that you are putting the hands in the proper position, especially if you're going to be using kind of this adjusted method where the watch may be hidden. Care should be taken to ensure that the fingers remain together and do not separate or splay. A relaxed positioning of the fingers, slightly cupped, produces a natural appearance. Cotton can be placed in the palm of the hands and the fingers curved around the cotton. Webbed cotton can also be wrapped around the fingers to bind them during embalming. If you have a lot of spread, webbed cotton pushes it all together. It's a great way of getting the fingers there. As soon as everything starts to firm, you can take the cotton away. That way you don't have any ridges. And if you really need to, a drop of super adhesive glue between each finger will keep them together when other methods are unsuccessful. Placing the feet close together and elevate them using a positioning device during embalming. When body height prevents proper fit into a casket of standard length, the knees can be slightly bent during embalming. Moral of the story, you really should be purchasing caskets or containers that fit the body comfortably, but if you are kind of stuck, by simply folding the legs at the knee just a little bit, that will get you a couple of inches of play so that everything will fit. The feet can also be manipulated to keep them at right angles to the leg. Omitting shoes may allow additional room in the casket. Every attempt should be made to avoid the need for an oversized casket. Now, what do they mean by this? Okay, this doesn't mean you shouldn't use an oversized casket. But if you use an oversized casket with larger exterior dimensions, you will have to use larger devices. You'll have to make sure that the grave is wider. You'll have to use an oversized outer burial container. And if you're doing something like above ground, you may find out that you have a problem with the crypt that you're trying to use, the mausoleum crypt. So whenever you start using oversized caskets, it's very important to communicate with all the parties in the process so that everyone knows what the expectation is. Take a measurement from elbow to elbow to determine the proper width of the body for proper fit in the casket. Width can be reduced during preliminary body positioning by keeping the elbows close to the sides of the body or by elevating the elbows to the height of the abdomen and bringing the arms across the abdomen. In other words, bringing them up this way. The arms and hands will not cover one another. They will remain adjacent. This draws the upper arms together and decreases the width. Turning the body slightly after placement will also help reduce body width, and conditions such as stroke and arthritis can contribute to positioning challenges of the extremities. Spinal curvature is a condition caused by severe forms of arthritis and osteoporosis. Arthritis cannot be relieved like rigor mortis. The joints are no longer flexible. Avoid over-manipulation of arthritic joints. Damage to bones, tendons, and soft tissues can result, and that damage can cause swelling. Numerous positioning devices will be necessary to maintain natural positioning during embalming. A manual aid such as splinting and wrapping a limb can be used to secure a limb in the desired position. Use of the common carotid and internal jugular vessels for embalming the legs is indicated when the femoral vessels are impractical. This is when you may have to go digging around to get a tibial or a popliteal artery. Supplemental hypodermic injection of the limbs after arterial injection ensures optimal results. Fancy way of saying is even after you've tried sectional injection, maybe you should go in with a hypovalve trocar and surface compresses. So setting features. The features are customarily set during the pre-embalming period. The features are commonly set during the pre-embalming period. Once tissues are embalmed, features may be less flexible for adjustments. Mouth closure and lip closure are two distinct procedures. Mouth closure raises and holds the jaw into position. Lip closure brings and holds together the mucous membranes of the lips. If your mouth closure is off, your lips will never look right. That is an important thing to understand. So, it gives you the sequence for mouth closure. That is an important sequence. One of four conditions exists when a mouth is set. You have teeth, you have some teeth, you have dentures, or you have nothing. Dentures are like any other piece of property. You cannot just throw them away. Many hospitals and nursing homes return them to the family with the belongings. When death occurs at home, whoever is transferring the body into the care of the funeral home should ask for the dentures in case the body is going to be prepped. It is possible to open the mouth after embalming and insert dentures, but it is infinitely more difficult if you're using strong, firm chemicals. If you do, relieve rigor in the jaw prior to cleaning the oral cavity. You want to be able to get in and access as much of the oral cavity as possible. If purge is present, you could use a nasal tube aspirator to aspirate purge material. I'm not going to say you can't do that. I'm saying that, generally speaking, a nasal tube aspirator is relatively useless, especially if you have lots of chunky organic material. So in those type of cases, I have just found that rinsing with water and then using a copious amount of either paper towels or cotton has been very effective, getting everything out. So everyone has different results with nasal tube aspirators, and I will tell you that different nasal tube aspirators have different size apertures on the front. That can make a big difference. And when using a nasal tube aspirator, the moral of the story is keep it away from the soft tissues of the cheek and the tongue because it will block the hole immediately. After you are done cleaning, disinfect the inside of the mouth and nasal cavity. So the throat and nasal cavities can be packed with cotton to control purge and odors exiting from the stomach or lungs. The cotton used for packing material can be coated with massage cream first. This prevents the cotton from absorbing purge materials from the stomach or lungs and also advancing those odors. Achieving the most natural expression of the mouth is subjective. Several photographs of the deceased are valuable in posing the feature appropriately. The upper mucous membrane is often slightly longer and thinner than the lower mucous membrane. Observed for dental prognathism or buck teeth caused by improper alignment of the teeth, resulting in a protrusion of the mandible. So an alternative to suturing is using a needle injector. A barb attached to a wire is driven by a manual device into the center of the maxilla or the upper jaw. Another barb is driven into the mandible in an opposing position. The two wires are then twisted together to hold the mandible in position. The barb embedded into the maxilla should be placed at the center where the two maxillae fuse. This is called the nasal spine, and the bone is quite generally strong. When dentures are available, insert them before using a needle injector. Upper dentures have a small notch in the center. Drive the barb into the maxilla at this location. Atrophy of the maxilla and mandible is common with prolonged denture wear. The needle injector is not effective when bones are porous, and the barbs will not stay embedded in soft bone or soft tissues, which is an extreme limitation for them. Tenuous fit may result in barbs coming loose and the mouth reopening. Suturing is the best method when the bones are soft. Me personally, I prefer suturing. The manual needle injector should be held at a right angle to the bone for best placement of the barb. An adjustment on the side of the device lessens the effort required to operate the injector. Electric needle injectors are also available. They are relatively expensive. If the jaw bones have been fractured, 4 injector wires can be used. Place one on each side of the fractured mandible and repeat for the maxilla. Cross the wires on the diagonal, making an X. Twist the wires together until the bones are properly aligned. So quite literally, you are doing something like that, and twisting it till everything kind of comes together. Best practice is to use an instrument instead of fingers. A hemostat can grasp and pull the needle from nostrils when it comes to suturing. So the first one we're talking about here is a musculature suture. Open the mouth and raise the upper lip. Insert the threaded needle at a point where the upper lip joins the maxilla under the left nostril. Guide the needle against the maxilla to prevent the needle from entering the tissues of the upper lip. If the soft tissues are caught by the thread, a pucker will result, and this will alter the appearance of the mouth. Slide the needle along the bone until the tip is visible in the left nostril. Grasp the tip of the needle with a hemostat and pull the needle and thread completely from the left nostril. Reinsert the needle into the left nostril. Keep the needle in the base of the nostril to prevent a thread from becoming visible, and direct the needle through the nasal septum into the right nostril and pull the needle and thread completely from the right nostril. Best practice, once again, is to use a hemostat for pulling the needle from the nostril. Then, insert the needle into the nostril, direct the needle towards the mouth, keep the needle against the maxilla, and push the needle into the area where the upper lip joins the maxilla. Pull the needle and thread completely from the mouth using a hemostat. So what are they saying? Okay, what they're saying is from under the lip, you insert the needle until it comes out in the nostril. What you'll then do is put the needle through essentially the septum of the nose, right up against the bone. Then you will insert the needle again, and you will come out from underneath the lip. Your maxilla has little grooves where the teeth are embedded into the skull. Those serve as natural guides for a needle going into the nostril, coming out and through, and then coming back in. When dentures are available, insert the lower denture into the mouth first, then place the upper denture. Keep the thread on the outside of the dentures. The point of the thread is to keep everything in place. Pull to extend the lower lip and insert the needle in the right of the mandible. At a point where the lip joins the gum, keep the needle against the bone. You'll see that here in this slide. Make a very wide stitch through the superficial tissues against the mandible from right to left. Pull the needle using a hemostat completely from the left side of the identical position where the lower lip joins the gum. Tie both threads together like tying a shoe, except wrap the thread twice instead of once. The second wrap will hold the thread in place and keep the mandible secure while completing the knot. Then adjust the lips for pleasing appearance. Now, when doing a suture, the key here is to get the mouth in the right position. As long as you get the mouth closure correct, the lips will take care of themselves. But if they're too tight, they're too loose, you'll have a problem getting the lips correct. Now, when doing sutures, typically the top portion of the suture coming in through under the lip and then out the nostril through essentially the septum and then down again from the inside of the mouth remains constant for all of the sutures. The nose portion remains constant for most of the sutures. What changes is the base. Okay, what changes is the base. So in a musculature suture, you're getting through the mentalis muscle. You're putting the needle behind the mentalis muscle at the base of the jaw. That is why it is called a musculature suture. With a sublingual suture, use a half-curved needle. That is a crescent needle, a half-moon needle. Pass the needle from right to left behind the lower set of teeth through the musculature and tissues of the lingual frenulum. Now, what you're doing here In a musculature suture, you're coming on front of the teeth, in front of the teeth. In a sublingual suture, you're going behind the teeth on the bottom. This prevents any puckering or issues because you're behind the teeth. The needle is then directed towards the maxilla, and everything happens the same. Remember, on a suture, the nose portion of it is the same for all of them. Last is a mandibular suture. Last is a mandibular suture. Now, with a mandibular suture, you are going around the bone. Disadvantages of the musculature suture and the sublingual suture is that if you start having a breakdown of tissues, if tissues start to dehydrate, that can cause the thread and the jaw to move. With a mandibular suture, you're going right around the bone itself, and no matter what happens to the tissues, that jaw is set, that mouth is not going to move. So the suture is passed completely around the mandible. This method is ideal when the deceased is shipped to a different location because the jaw will not separate during transport. Open the mouth and insert the needle between the lower set of teeth beneath the tongue near the lingual frenulum. Push the needle downward into the base of the mouth through the soft tissues and exit below the chin. Pull the needle with a hemostat completely from the tissue. Allow a length of thread to remain in the mouth. Reinsert the needle into the hole at the base of the chin where the needle first exited. Pass the needle upward just in front of the center of the mandible where the lip meets. And now the suture has passed completely around the mandible. So what is happening, if we go back here, is your bone is right here. Now, there's a couple of ways to do this suture. There's two ways you can do this suture. If you have access, you can go from the inside out and then back again through the same hole. Another way you can do it is to go in from the bottom, behind the bone, then take the needle out, put it on the other side of the suture thread, go in the same hole, and this time you come through the front. So there's no poking through the mouth and down. It's both times you are going from the bottom through the top. Me personally, this is the suture that I would use almost exclusively, 99% of the time. The reason for this is once this is set, it is done. That jaw will not move again. So it does leave an unsightly hole. You have to take steps to hide that. But if you can get it so that hole is not visible, this is an ideal way of doing it once and never having to do it again. Once you have secured the mandible, you have to pull the thread in a sawing motion several times. What this does is it cuts through the small amount of tissue here in between the bone and the skin and gets the ligature right up against the bone. Because if you don't do that, the first thing is it may cause an unsightly pull or a dimple. The second thing that could happen is as the tissue dehydrates, the mouth moves. So the goal is get it up on the bone, saw through any small amounts of the tissue till it's right up against the bone, and then the upper portion of the suture is the same as all the others. The small exit hole beneath the chin created by the needle is easily concealed with restorative wax, not even cosmetic. Sometimes you can get away with just wax. Complete the upper portion the same as a mandibular suture. Now, there is another one called a dental tie. This is a pretty cool suture. This can work very, very, very well. Problem is you have to have natural teeth for this. Now, it says a full set of natural teeth. I've seen people do a dental tie variation just with a couple of teeth. But you need one on the top, you need one on the bottom, ideally. Otherwise, you need at least one on the bottom. A thin thread of dental floss or a ligature is tied around the base of one tooth on the upper set, one on the lower set, and then you tie and secure the jaw. What I've also seen is you tie on the bottom and you do the upper portion as a suture. Numerous dental ties can be placed. Really, it's just limited by the amount of teeth that you have. And here's the alternative version. Tie the thread around the base of one tooth and then thread it towards the maxilla. In other words, you do the top portion of the suture and then tie it off. Drill and wire is also possible. This method is used in trauma restoration. Fractured and missing bones are replaced and aligned piece by piece and secured with wire. And as the name implies, you take a drill with a very small bit. You start making holes where you need to. You pass wires through them. The barb injector wires are very useful for this. You cut the barb off, then use the wire by itself. I've also seen people use gauge wire, very, very small gauge wire from home improvement stores. So you get some sort of insulated wire or something like that. I'm not saying they all do that. The most common thing that I have ever seen used is barb injector wires. But I have seen it once where they just use like 22 or 24 gauge electrical wire and use that instead because it is a bit more rigid than the needle injector wires. Gluing using adhesives is common for children and infants. The issue is, once you've set the glue, you really don't want to play with it again. And the problem is, because you're gluing lips, the mouth may move, the bone may move, the jaw may move, and then that creates an inconsistency. That's kind of the disadvantage to using adhesive by itself. The chin rest is a historical device. The device consisted of two small prongs that are inserted into the nostrils. Attached to the two prongs is a sliding support, which is placed beneath the chin to secure the chin in the desired position. What it did, it had two prongs. You looped it into the nose, and then you tightened it to the mouth where you needed it, right? Then you injected a very strong preservative solution. You fixed the face, you bricked the face into that roll, and then you could take the chin rest out, and the preservative reaction would hold the mouth closed at that point. So this wouldn't be something you'd leave in. This would be get the jaw where you want it, inject a very strong solution with very high degrees of firming, and then once everything is firm, take the chin rest out and you're done. This method depended on the fact that things were very firm, and these days that is very hard to get with people who have had multi-drug therapies. Natural teeth create the foundation for natural facial expression. The mouth is an essential part of overall expression. When several teeth are missing, appearance is altered. Several materials are used to fill areas where teeth are gone to establish the natural curvature of the mouth. When all of the natural teeth are missing and dentures are unavailable, pack the throat and oral cavity, and then you're probably going to have to use a mouth former. A mouth former can be placed to create contouring of the mouth and align the lips. Some mouth formers have holes through which needle injector wires or the suture thread can be passed. Mouth formers are available in a variety of sizes, different types of materials, and you can even trim them to fit. Numerous other materials can be used in place of a mouth former: cotton, mortuary putty, mastic, whatever kind of floats your boat. If cotton is used to replace missing teeth, apply long strips to cover the mandible and the maxilla. Add strips of cotton to create natural form and contour. Model the upper integumentary lip first. Important thing about when using cotton. Cotton is a wicking material. So if you are adding this in and you have moisture and moist tissues, it will pull moisture from those tissues. So that means you may have to cover that with some small amount of massage cream or other barrier so it does not dehydrate the tissues it is coming into contact with. When there are dentures but no natural teeth, once again, insert the dentures prior to using any sort of closures. Dentures should be cleaned and disinfected first. And you can simply use a topical spray, soap and water to clean the dentures so that they are free of biological material. Cotton can be placed on the tongue to help hold the dentures in place, and you could even use a mandibular suture to secure the lower dentures. If the denture does not fit well, use the upper denture and vice versa. Use what you can. The upper denture gives the best foundation for the curvature of the mouth. It can be held in position by placing cotton or mortuary putty in the area normally occupied by the lower denture. Fancy way of saying, get the upper denture in and then fill the bottom half of the mouth with whatever you can to keep the denture from falling out. And if the dentures don't work at all, don't use them. But then take the dentures and either put them with the deceased or ask the family if they'd like them returned or discarded. General operating practice, keep the denture with the deceased. And if you promise the family that you are going to use the dentures, you must use the dentures. When you give an affirmation that you will do something, you have to follow through on that affirmation. When placing dentures in the mouth, always insert the lower denture first and then the upper denture. There is only one time you would do this in reverse, and that is with a reverse prognathism, where you have an underbite. The moral of the story is you insert the denture that is going to be covered first. Normally, we have an overbite on most facial expressions, so the bottom denture goes first, and the top teeth cover the bottom teeth. That is what you're looking for here. Whatever teeth get covered get put in first, and the teeth that do the covering go in second. In most people, the line of mouth closure where the two mucous membranes meet is located at the inferior margin of the upper teeth. Establishing the curvature of the upper integumentary lip is key to a natural appearance. Fancy way of saying, where your upper teeth stay, right here, this is where the line of demarcation, where your lips abut, should be. Right below the upper teeth, or right in front of the upper teeth, at the lower margin of the upper teeth. There are occasions where rigor is so intense that jaws cannot be opened. It is still wise to use some form of mouth closure. If dentures are in the mouth, it's impossible to remove them for cleaning. Spray disinfectant and try to clean what you can. Okay, the moral of the story is always try to do something. After the mouth has been closed, the natural line of closure is established. The mouth is convex in curvature from corner to corner. In the bilateral view of the mouth looking upward from the chin towards the forehead, the convex or horseshoe curvature of the mouth is easily observed. Retaining this curvature avoids making the mouth look flat with a straight line of closure. The center of the mouth is the highest projection. Again, the line of closure is along the inferior margin of the upper teeth. A small amount of cotton inserted high on the maxilla on a line from the corner of the mouth to the center of the closed eye helps to raise the area surrounding the corners of the mouth, called the angulus oris eminences. The corner eminences can also be defined with tissue builder following the arterial embalming. Fancy way of saying, if you follow the center of the eye down to your lips, there's a little bump here in the angle of the mouth. That is the angulus oris eminence. You can create that by putting cotton underneath or putting some tissue builder in position and puffing it out. I personally would use cotton 100% of the time. The upper lip or superior mucous membrane is usually thinner and longer than the inferior mucous membrane or lower lip. The appearance can later be highlighted when cosmetics are applied. The weather line, the line of demarcation between the moist and dry portions of each lip, determines the line of closure. Proper lip closure allows the lips to abut but not overlap. You can see the lips come together right here. This lip on the top is not hiding the lip on the bottom. They are abutting. Remove any debris on the lips prior to embalming. To hold the lips in position during embalming, the following products can be used. You could use a lip seal cream, which is generally a very sticky, a very thick massage cream. Petroleum jelly works great in a pinch, or even lip glue. A super adhesive glue is not customarily used for temporary closure because it is a pain in the butt to clean, and you're not looking for a permanent closure at that time. Another way that you can keep the lips in place is you take strips of Webril cotton, you put it under the lip and push it up. You take another one over the top lip and then drape it down, and the wet cotton will keep the lips kind of together. Now, you have to be very careful when doing that because if you are using a fast firming fluid, that cotton, if it is too tight, will create a ridge. And then that will be permanently preserved onto the face. So if you are using the wet cotton strips, be very careful that you're observing if they are too tight or not. Application of a lip cream to the lips during embalming will hold them in position and also help to smooth wrinkles on the lips. Natural wrinkles or lines in the mucous membranes are vertical, but lines from dehydration are horizontal. So if we come back over here, you can see that we have lines on the lips. For the most part, these are all vertical. These are all vertical. When we start seeing lines coming across, that means our lips are dehydrating. It is usually easily fixed when you are injecting your arterial solution. Your body will naturally rehydrate unless it is so far gone that you simply can't. There are also some other excellent things that you can do regarding that. A surface application of a humectant fluid. I've had good results by soaking some cotton in Dodge brand restorative, placing them on the lips for a period of time, checking them, and that will rehydrate lips. I've seen that happen. That's usually pretty effective, but sometimes they're just too far gone. Place a very thin film of lip cream on each lip and then bring the lips into contact. They will pull away from each other slightly. In doing so, the horizontal wrinkles will be removed as the lips stretch. After embalming, wrinkled lips can be corrected by gluing, tissue building, or waxing. Some embalmers find it helpful to keep the lips slightly separated during arterial injection, which allows the mucous membranes to contour as they expand. That's also a thing. This is why you want to be able to correct your lips as you inject, because of the fact that as they rehydrate, if they quote-unquote are perfect now, they will then start to swell and start to purse together. This is why you want to be able to make corrections. If the lips are glued temporarily, they should be reopened after embalming to release any material present. Air from the lungs can be forced into the mouth during aspiration of the body and can be released when the mouth is open. You can then permanently glue the lips shut. Eye closure. In establishing the line of eye closure, the upper eyelid or superior palpebra forms 2/3 of the closed eye. The lower eyelid or inferior palpebra forms 1/3 of the closed eye. So if here's my orbit, my eyes are something like that. Here is the superior palpebra, here's the inferior palpebra. What we should not see is something like this, where it's right down the middle. That's squinting. The line of closure is located in the inferior 1/3 of the eye orbit. The line of closure is curved. The inner corner of the eye, the inner canthus, is slightly higher and larger than the outer corner, the outer canthus. Eye closure is customarily done prior to arterial injection. It can be done in other places, but the best time to do it is prior to injection. The eyes can be cleaned with moist cotton. Like all areas of the body, the eyes should be sanitized using a topical non-astringent disinfectant. In addition to cleaning the surface and corners of the eyes, clean and align the lashes. Don't just close the eyes and forget about it. It's always really nasty to go in and pay my respects and I see that the eyelashes are all gunked together with massage cream because no one took the time to comb them out afterwards. Cleaning the eyes also helps to relieve rigor mortis in the muscles of the eyelids. If the face is emaciated or dehydrated, the eyelids may have to be stretched slightly to improve flexibility for proper closure. This can be done by inserting the smooth handle of an instrument, such as an aneurysm hook, beneath the lid and gently stretching the tissue. If you have to go to the more nuclear option, you can take a scalpel and cut away some connective tissue, and then you have to recontour the eye. I've had to do that a couple of times, but realistically, the vast majority of cases, just take the handle of an aneurysm hook or some other blunt device, run it through the inside to help break a little bit of that rigor, and your eyelid will be fine. Establish the anterior projection of the closed eye and secure a lid closure by inserting cotton and or an eye cap. Preferably eye caps. I'm not saying you can't use cotton for it. People have done it for years. I just like using eye caps. So here you can see a properly closed eye. You can see that the inner canthus is there. Here's your outer canthus. This looks pretty good, right? Here's your 2/3 of the eye. Here's your 1/3 on the bottom. This eye looks pretty good. Close the inner canthus to prevent dehydration in this area. The moist tissue of the inner canthus will shrink and darken if not properly closed. Now, one thing that you can do if you absolutely need to do it is you can get a little bit of wax and close the inner canthus with that little bit of wax. Or at least plug the canthus with the wax so more dehydration doesn't occur. Eye caps resemble a contact lens. They are designed to cover a larger surface area than a contact lens, and they are usually perforated. The ones I always used were perforated. And the reason for that is that provides the tension, it provides the friction to prevent the eyelid from creeping up should it try to do so. Should the eyes be sunken, you could use several caps or caps with putty or cotton to elevate closed eyeballs. Now, another thing that I would do, and I found to be very effective on most cases, is I would take tissue builder. I would put it into the orbit of the eye, because that usually the cases I would embalm, the eyes are almost completely deflated. All of the liquid of the eye is basically dehydrated. So I would go in and I would fill the eye back up with tissue builder. Now, tissue builder is self-closing. So, yes, you're going to have a little bit of leakage for a second until the hole plugs, but once it does, you're good. And then from there, add your eye cap or cotton. If you want to rebuild the entire eye from scratch with nothing but cotton and eye caps, go for it. I found that by using just a little, by reinstating the eye with tissue builder, that went a long way to getting my eye looking natural. And the other thing that I would do is, if it needed just a slight correction, I wouldn't be afraid to go behind the eye and put a little tissue builder there and push everything just a little bit forward, just to make it look nice. I'm not saying that an eye cap wouldn't solve that. I'm saying that is an alternative method, that if you just happen to be out of eye caps, your shipment didn't come in on time, there's some well-placed tissue builder behind the eye itself can push everything kind of forward just to get that little bit of space that you're looking for. So cotton may be placed under the closed eyelid to keep the lids closed, elevate the lids, and establish the convexity of the closed eye. Lift the upper lid and insert the cotton under the upper eyelid with the handle of an aneurysm needle or forceps. Lift the upper eyelid over the cotton and place it in its proper position. So what you see here is this, okay? This is the handle of an aneurysm hook or an aneurysm needle. This is one of our blunt dissecting tools. And if you look closely at this bottom picture, you can see the perforations in the eye cap right there. Evert the lower eyelids and insert cotton into the area covered by the lower eyelid. Then lift the lower eyelid into position. After several injections, if the eyelids do appear too soft, you could add some cavity fluid on the cotton to help give a little bit of something there to add some preservative and kind of treat that small amount of cotton as a cavity pack. You don't want to go too crazy because you don't want them dehydrating. In cases of extreme emaciation, postmortem dehydration, or if the vitreous was removed from the eye globe during autopsy, the eyes can be sunken and the globe dehydrated. The globe can be rounded or inflated by direct injection of tissue builder. I've already talked about that. And then you could use some super glue to prevent any further loss of fluids. To bring the eyelids together, the lids may be exercised and stretched. Sometimes they may even be cut. Now, this is an important thing. Like your lips, your eyelids abut each other, right? If we go back to the picture of the gentleman's eye when closed, you can see that there is a very clear margin of the upper eye, and there is a very clear margin of the lower eye, and they are touching each other. They are abutting. They are not overlapping. They are abutting. However, in certain cases, damage, trauma, etc., you may have to overlap. You may have to overlap. So overlapping is permissible only as an absolute last-ditch effort to get it to look right. But it is not customary to overlap the eyelids for general purposes. To control dehydration, place massage or stay cream on the cotton or eye caps. Stay cream is also like lip adhesive. It's a very tacky, very adhesive type of wax, petroleum jelly, whatever it is. Cotton can also be saturated with a supplemental humectant fluid. Now we're into packing the trunk orifices. Deep breath. A topical spray disinfectant is reapplied to the areas surrounding the anal and vaginal orifices prior to treatment. Long strips of saturated cotton are inserted with packing forceps into the orifices. Phenol solution, undiluted cavity fluid, or autopsy gel may be used to saturate the cotton. Typically, I use autopsy gel. This treatment may be repeated after embalming if discharge of fecal and other material occurs during embalming. And then a threaded closure device may be inserted following the cotton packing to prevent further discharge. Invasive medical devices may be removed by the embalmer before, during, or after embalming. Any device that poses a hazard or interferes with arterial embalming is removed prior to embalming, disinfected, and properly disposed of in the biohazard waste container or, if necessary, a sharps container. Any device that could potentially mark the tissues of the face are also removed. So, the general rule of thumb, if it is marking the face, it has to go prior to embalming. If it is marking any visible area of the body, it should be removed prior to embalming. If it would interrupt your vasculature, you leave it until after embalming. So, for instance, if you had a device hanging out the side of the mouth, that's got to go because it's going to misshape the lip. But what if you had an IV PICC line stuck in the back of the hand? This is a visible area of the body, is it not? Problem is, that line is inserted into your vasculature. And if you remove that right now, as you inject, it's going to come right out the hole you just made. So you would leave that in place for the duration of the embalming, and then take it out and seal the hole after the fact. So anything that messes with your arteries or veins, leave in place. Anything that messes with appearance, especially of the face, that has to go. Implantable devices can be removed before or after embalming. Implantable devices containing batteries must be removed prior to cremation. You can absolutely bury someone with a pacemaker. You do not want to cremate someone with a pacemaker. Generally speaking, removing a pacemaker after embalming is perfectly fine. Removing a pacemaker after embalming is perfectly fine. I would not do that prior to embalming. Okay, I would not do that prior to embalming. Implantable cardioverter defibrillators and pacemakers are usually visible in the upper chest. They can be in other areas, but they're generally up here somewhere in the torso area. You can easily feel it beneath the skin. Usually, it says it is easily palpated, easily felt beneath the skin. A small semi-lunar incision is made with a scalpel along the superior border of the device. As the device is removed, two electrical leads are exposed. The best practice is to cut each lead independent of the other with surgical scissors. Fancy way of saying, don't try to cut both wires at the same time. Cut one, cut the other. That way it's easy to cut, and you're done. And you can see after you're done, it's a pretty simple incision. Just more incision practice. Proper removal and disposal of medical devices should follow the instructions on the authorizing agent or next of kin. Disposal may be contained in the language of embalming and cremation authorization forms. Medical devices that should be discarded are placed in appropriate sharps or waste containers and then suture the incision. Generally speaking, if you are doing an embalming for a ground burial and you see a pacemaker, you do not have authorization to remove the pacemaker, unless your authorization says you do. Most embalming authorizations will not cover that. Okay, most embalming authorizations that I have seen do not cover the removal of a pacemaker. Pacemaker removal is usually covered in a cremation authorization. But until they sign the cremation authorization, you do not have permission to remove it. Bonding agents and superadhesive glues may also be used to close a pacemaker incision. Leads that pass through the subclavian and cephalic vein can interfere with blood drainage during embalming. I have embalmed plenty of bodies with pacemakers. I can't really say that I have ever had an issue with a pacemaker making my life so miserable that it doesn't work. That's all I'm going to say. Recent surgical incisions can be a source of infection. Liberally disinfect the area during the initial bathing. Surgical incisions are particularly dangerous, folks. Staples or sutures can remain in place when secure and no leakage is noticed. So if there's a suture, if there's a surgical incision, you're injecting and nothing is happening in regards to it leaking or being a problem, just leave it as is. You don't have to go crazy. If it starts leaking and losing its mind and stuff like that, you're probably going to have to do something about that. Hypodermically inject a cautery solution into marginal tissues. Apply a cotton compress over top, and then plastic wrap is used to contain chemical fuse while the pack is in place. So the moral of the story is, because these are dangerous, they may be infected. One, treat the edges with a cautery agent, then put a compress of cautery agent over the top of it, and then cover that with plastic because fumes can be nasty. If the incision has to be opened, that's fine. Take out any staples, take out any garbage that's in there that shouldn't be there at this point. Add your sealing powders. If you need to go in and clean it, if you need to add cotton and cautery agent, there are all sorts of things that people will do if they have to go ahead and open a surgical incision. Kind of a best practice is like what it just said. If you have to open the incision, treat the edges with cauterant, pack with cotton, maybe apply some more cautery chemical, put some surface sealer on top of it, and then suture it like normal, being very careful not to grab the cotton as you suture and pull it through any one of the holes. Once you're all done, apply a surface sealer. You probably need something a bit better than pore sealer. So you might have to get something like True Seal or one of the more quote-unquote rubber cementy types. Hey, that's fine. Wait till that's done, and then final bathing. You could also wait till after you're done and then apply the really nasty sealer, so that way you can get the terminal disinfection out of the way. Tubes that enter the mouth or the nostrils should be removed or extubated in the pre-embalming period. You basically see a worst case scenario. You would never want to embalm a body with any of the things you see here in place. All of that has to go. If these are left in place for any amount of time, especially if using a strong fluid that's fast firming, that's going to leave all sorts of nasty marks and stuff on the face. When the tubes have been in the patient's mouth or nose for several weeks, the surrounding skin may become compromised. Fancy way of saying the skin might start turning necrotic and it's forming wounds. Massage of these areas during arterial injection may help to restore them to their natural contour. Again, this is if it's still relatively fresh. If this stuff has been in there for months and months and months, there's no way you're really going to be able to close the hole that is now left from that just sitting in the side of the mouth for several months. Cotton saturated with a disinfectant or cautery agent can be placed in the surgical opening to disinfect the respiratory passages. Close these openings after arterial embalming. So now we're talking about tracheotomies. Should any purge develop in the lungs or stomach, the surgical opening provides an outlet for the purge material, which is why you should close it up. So go through, pack with cotton, put in your sealing powder, purse string suture, and then some sort of sealant on top of that. After you're done, you could add, if you're using the proper types of sealant, you can apply restorative wax or something to conceal the closure if you need to. An endotracheal tube is placed into the mouth, then into the trachea to assist with breathing. The tube is connected to a ventilator, which delivers oxygen to the lungs. Endotracheal tube should be removed or extubated in the pre-embalming period, and the area should be disinfected. Again, an endotracheal tube is going in and harming the face if you embalm. It's got to go. Nasopharyngeal tubes inserted into the nasal passageway. Once again, it's marking the face. It's got to go. Here's your classic tracheostomy. These should be removed in the pre-embalming period just because it can collect all sorts of garbage. And also, if you are wanting to use a carotid incision, all this stuff here is in the way. If you are using a femoral incision, this would be of likely no concern. The only thing you'd want to pay attention to is anything here going to mark any of the visible areas of the face. But generally speaking, tracheostomies, any tubing up there should be removed in pre-embalming period. Abdominal feeding tubes, I really would never play with these until after embalming. No reason to take them out. The abdominal feeding tube is inserted into the stomach through a small incision in the abdominal wall. Feeding tubes can be removed before or after arterial embalming. Here you see an example of that. You can see this person's probably had some sort of abdominal resection. You can see the scar right there, so that can give you some ideas of what's going on. Wrap the tubing first with cotton. Pressure is released when the tube is cut. Material contained may discharge. The tubing may be fully extracted fully, or a segment may retain internally. Again, this is up to you. Me personally, I would wrap with cotton. I pull it out a little bit. I cut it just above the skin, which causes typically the hose to pop back inside. And then I use the same incision if it is small enough for my cavity embalming. If this hole is too large, if it's gone necrotic, or I can see that I'm going to have trouble closing this with a purse string or something, which is very rare, but just saying in case you run into that, you're probably best getting that sealed up as much as possible because you don't want those fumes to come out and start attacking you as you are applying your cavity fluid. Disinfect the area after the tubing is withdrawn because all sorts of nasty stuff is in your guts. Insert cotton saturated with phenol, autopsy gel, or undiluted cavity fluid into the opening using a forceps. Close the opening with a purse string suture, a large trocar button. As you do this, you will see and get a good idea of what you can close using what techniques. But again, the moral of the story is if you can use this hole for cavity embalming, great. That means you don't have to make another one. But you do want to make sure that you're going to be able to effectively close this when you are done so that you are not unnecessarily exposing yourself to cavity fluid fumes. Depending on the location of the feeding tube, the opening may be used for cavity aspiration. There you go. This also holds true for colostomy stomas. There are different schools of thought on the colostomy stomas, and we'll get to them when we get to them. Surgical drains can be removed before or after arterial embalming. Drain openings should be packed with cotton saturated with phenol, autopsy gel, or undiluted cavity fluid. Small purse string suture will make your life easy, and this should be done prior to cavity embalming. Again, close extra holes that you're not going to use so that you are not exposing yourself. And speaking of our friend's colostomy, a colostomy is a surgical procedure that diverts a section of the colon to an opening in the abdominal wall. Stool drains in the collecting bag from this opening, called a stoma. The collecting bag can be removed either before or after arterial embalming. Once the collecting bag is removed, the stoma is visible. Irrigate any remaining fecal material and thoroughly disinfect the area. Place saturated cotton over the stoma and push it back into the abdominal opening. Close the opening with a purse string suture. Surface glue and cotton can be applied to prevent any leakage. So the moral of the story is get everything back inside the hole, pack the hole, and then tighten it up. And there you see a pretty picture-perfect purse string suture. And as the name implies, I know we'll get the sutures again later, all you're doing is going in and out around the margin of the hole. The important thing here is that you try to maintain the same distance between the margin and the holes throughout the entire thing. Then you pull it tight, and it all squeezes together. Disinfect the collecting bag prior to disposal. Pour a few ounces of undiluted cavity fluid or other mortuary disinfectant into the bag and discard in an approved biohazard container. Again, different schools of thought on colostomies. For testing purposes, we remove them as you read here, okay? For testing purposes, you're absolutely going to remove it as you read here. You're going to add in, quarter bottle or so of cavity fluid and dispose of it. I do know practitioners who basically do not play with these at all. If it wasn't a mess in life, it's not going to be a mess in death. They leave the bag attached after they're done cavity treatment. They take some packing tape and they tape the ostomy bag down so it won't move. And they leave it in place and for disposition. I'm not saying it's right. I'm not saying it's wrong. I'm not saying it's ethical or unethical, moral or immoral. What I am saying is I know practitioners that do that, and realistically, if you don't want to play with the colostomy bag and it is not messy, it is not coming off or anything like that, you likely don't have to worry about it. That's the truth. IVs, intravenous catheters, can remain in place until arterial embalming is completed. These invasive devices did not hamper circulation during life, and leaving them in place will not interfere in death. They can be removed after arterial and cavity embalming is completed. Leave your IVs alone. Unless there is some superseding reason for you to play with it, leave it right where it is. Because if you take it out, it absolutely is going to leak and cause you problems. When these tubes are removed from the areas that will not be seen after the body is dressed, their openings can be enlarged with a scalpel, and a trocar button can be inserted to prevent leakage. If you want to go that far, you could do that. I also know that there are practitioners that if this is in a non-visible area, once again, they just tape it down, and that's that. The IV is non-visible. Hence, if I leave it in place, it is not going to cause me a problem because there is no hole. But the moment I take this out, I have created a hole and I have to protect against leakage. I'm not saying it's right. I'm not saying it's wrong. I'm not saying it's moral or immoral, ethical or unethical. I am saying there is a strong argument that people have to say, hey, if no one's going to see it, and if I take it out, it could cause a problem, I'm just not going to take it out. Super glue adhesive can be applied to the same IV openings, especially in visible areas such as the back of the hands or the neck. That is the most common thing that I would use to close these things up, is good old-fashioned super glue. Cauterant can also be injected with a fine needle and syringe directly into the opening to prevent leakage. Key thing there is a very small needle. Okay, a very small needle. You go in there with a very small needle. If you go in there with a big honking needle, you are causing more holes. Your goal here is to work within the hole that is there, burn whatever you can from leaking so that when you apply your surface sealer or your surface adhesive, that it will not leak. That is the moral of the story. If you have wrinkles on the back of the hand, one of the ways that you get away with hiding these is you put the super glue in place and you pinch it shut. That way, it's hidden by the fold and the glue keeps it shut. There are all sorts of ways you can hide these things. But again, going back to my buddy Jay. Jay was a master at this stuff. I would see him just go in there with a small gauge needle, channel around a little bit, insert the drying, wait a little bit, squeeze some of that stuff out, and that's it. That's done. That's not going to leak anything. You'd apply a little bit of pore sealer or a little bit of super glue and pinch it shut, and good to go. I've also seen other people try that with larger needles, and they make a mess of things. Urinary catheters. A catheter can be inserted into the urinary tract through the urethra or the abdominal wall. It can be removed prior to arterial embalming. Cut a small side vent into the catheter tubing with scissors to collapse the balloon dilated within the bladder, and then pull the catheter from the body. Two ways you can do this. You could either do it that way, or just about every funeral home has a Luralox hypodermic syringe. You screw that into the port, and then you remove the liquid that has the balloon inflated, and you could just slide it right out like normal. So either if you're going to cut it, make sure you cover where it is you're making that hole, because that can induce some spray. If the catheter was inserted through the abdominal wall, purse strings, or trocar buttons, notice the moral of the story. If anything has caused a hole somewhere, a circular hole, purse string sutures, or trocar buttons. That's how you close those. If the urethra can be packed with cotton saturated with cavity fluid, autopsy gel, or cautery chemical after you remove it from a female, this goes to what people feel is appropriate when working in the vaginal orifice. I have removed them, and I use AV plugs. I almost exclusively use AV plugs when I have them around, and I would, as a general statement, use an AV plug exactly what an AV plug is intended for. Just saying. The two most common types of casting material, if you're going to get with cast, are plaster and fiberglass. A vibrating cutting saw is used to remove the cast. Cast should be removed whenever possible prior to embalming. This allows inspection of the casted areas so you can see exactly what is happening there and what treatments you may have to perform. Leaving a cast in place means that you cannot ensure that the solution is getting there and the area is getting preserved, and you also have to now protect the cast. When the cast must remain, get that cast out of the way and then cover it up with plastic and anything else you can to prevent it from getting damaged or soiled. If you have external orthopedic devices, I am telling you, most markets, this is going to be very rare. External orthopedic devices used for fixation of traumatic bone injuries may be removed before or after embalming. Tools are needed to remove the hardware from these devices, pliers, drivers, all sorts of fun stuff. the metal rods penetrating the bone are firmly set. So moral of the story, you need to have tools to be able to work on these things, and it's nothing a quick rundown to Harbor Freight can't possibly correct. If you have questions on any of these sort of things, I am telling you, contact the orthopedic doctor or surgeon's office and say, here's my situation, here's what I have on my table. Could I ask one of your techs to come down to remove this thing? I will pay them $100 for them coming down to do this. And they will be happy to come down generally on a lunch hour or something and take care of this for you. Doctor won't do it, but the grunts in the office will be happy to do that. And that is true for casts. Now, back in my day when dinosaurs roamed the earth right before the meteor hit and caused the Great Depression of 1930, we had a situation where we would actually have to go to doctor's office, meet their staff, and give them death certificates. I know, it was the wild, wild west. Well, one of the benefits of that is you can form relationships with the people in those offices. So if you call over and you know that there's an orderly you usually work with, you say, hey, Mike, it's Joe over at the Reese Funeral Home. I run you DCs all the time. Hey, listen, I got a cast here in my prep room. Can I give you like $40 and buy you lunch if you come on down and cut this thing off for me because I don't have the saws or anything? And I will tell you that I had a doctor's office 10 minutes down the road from the funeral home that if I had a situation like that, I could call the guy, and for $40, he would bring the saw, chop it off, and be back on his way, and we didn't need to have a cast saw, just sitting under a cabinet somewhere waiting to be used. So the entire time I was in practice, we had to do that twice. Could we have bought a saw? Absolutely. Could we have figured other ways of doing it? Absolutely. Is it better for me just to have the guy with the saw come down, take his lunch hour, and get a free lunch off of me? Win for him, win for me. This type of activity poses an extra injury risk to the embalmer. Extra caution must be exercised. A team approach is recommended, so one embalmer can stabilize the device in extremity while the other removes the hardware. Again, if you are unfamiliar, you don't have a team environment, you can learn as you go, or you can contact someone's office that does this and say, hey, if I pay you, will you come down and I'll buy pizza for your office? And that might be the best $40 at Papa John's you've ever spent. Although these days, $40 at Papa John probably gets you an order of breadsticks and maybe a 2-liter of Pepsi. I can't remember if it's Pepsi or if it's Coke. Go ahead and drop that in the comments if you want to comment on the video, just because I think it'd be funny in a couple years if someone says Pepsi on one of my videos. And I'm like, the hell is that about? Most of the treatments that follow employ concentrated solutions that contain either formaldehyde or phenol, so obviously PPEs are in order. Here are some general pre-embalming treatments. When you're using formaldehyde, phenol, or bleaching surface compresses or gels, cover them with plastic. It controls the odors, controls evaporation, which, yeah, we want to keep you safe, but this is super important here because you don't want these things to evaporate. If they evaporate, they're not doing the job you put them on the body for. And the last thing is you're not going to get high off of this, so inhaling these things offers zero benefit, even recreationally for you, so just don't do it. Hypodermic syringes should be flushed with tissue builder solvent after each use, so if you're using tissue builder, remember, do not use water to flush these things. Essentially, tissue builder solvent is methanol, plain old methanol. So if you run down to Home Depot and pay like $20, you can get yourself a gallon of methanol in a can. You probably have enough tissue builder solvent to last you a year. When injecting the face with chemicals other than tissue builder, the point of entry, when possible, should be hidden. Should be hidden inside someplace, since anything other than tissue builder creates a hole, and the hole will leak. Injection on the back of hands can be done by entering the hypodermic needle into the webbing between the fingers. Some leakage can be expected, and this should stop in a short period of time. If not, good old dab of super glue and then closing it will fix that issue right quick. Discolorations of the face, arms, and hands should be carefully examined before arterial injection. And the reason is, you're going to want to know if this is clearing or not, because if it clears, then you know you're getting the job done. If you aren't paying attention and you don't know if it's clearing or not, if that was there prior or whatever, that is an issue. My greatest curse as a clinical instructor, is I let my students do the embalmings, and then I am making observations and doing things, and I am not doing what I would normally do in professional practice because I'm having to instruct students, I am guiding, I'm letting them do trial and error. So every so often, a discoloration would get by me because maybe I'm running 2 tables that day. And as I'm making some notes, I step to the other table while table 1 is undressing. By the time I get back, I don't notice a discoloration, and then I have to say, hey, was that on here before or after? And there are other times where I would absolutely do that to a student just to remind them that they need to be looking at that stuff. Hey, was this here before or after? What's going on with this? Is it getting lighter? Is it not? You tell me. That way they get put on the spot. Visible discolorations. First up, we have livor mortis, an intravascular blood discoloration. Once hemolysis occurs, postmortem stain is extravascular. Stain cannot be cleared, but it can be bleached and lightened. Stain cannot be cleared. It can be bleached, it can be lightened, but it's never going to be picture perfect. Livor mortis can be distinguished from stain by applying digital pressure to the discoloration. That doesn't mean take your webcam and smack it up against the stain. It means take your digits and push on it. And if you push and it turns white or the discoloration disappears, that tells you you're dealing with an intravascular discoloration. And if your fluid is getting in there through diffusion or through distribution, you should be able to push that out of the way and let it empty as drainage. If it does not lighten, you have a stain, plain and simple. Livor mortis can be removed by elevating the affected tissues. If you just put the arm up, all that livor mortis will drop back into the shoulders because it is intravascular. It will flow in the direction gravity pulls it. Livor and stain can occur in the same tissues because livor mortis precedes stain. Now, people for years said, hey, we can bleach this stuff. I'm sure you can. And I have argued that the bleaching occurs because you are flushing the stuff that you can, and the stuff that remains is now going to be lighter because the darker undertone is gone. And that's just my theory on it. I have never seen stain bleach so effectively that it's almost gone. Stain is stain. Refrigeration, blood thinners, and carbon monoxide all speed hypostasis of the blood and the resulting livor mortis and postmortem stain. If it is more liquid, it will flow quicker and it will pool that much faster. And if it breaks down, you have a problem. Elevation of the shoulders and head will prevent the occurrence of livor mortis. If already present, elevation will promote drainage of livor mortis from the facial tissues. Ecchymoses and purpura are localized antemortem extravascular blood discolorations. These conditions are frequently seen on the backs of hands. These discolorations cannot be removed, but can be bleached. When you apply bleaching agents, they also dehydrate, so keep that in mind. You're trading one discoloration for another. Now, ecchymoses and purpura. Both of these are the same things. It is a bruise. Okay, these are bruises. They're going to look like bruises. What matters there is size. There's large, medium, and small, and we will see what that is coming up. The treatments that follow ensure good preservation of affected areas. Subcutaneous hypodermic injection using a phenol bleaching chemical or undiluted cavity fluid before or after arterial injection. Strictly speaking, if I'm going to be doing bleaching like this, I am only going to do it after arterial injection. When I go in with my needle, I run the risk of poking something I shouldn't. So, as a result, I am just going to play it safe. I'm going to inject my body, and then after I have secured my preservation, now I will worry about bleaching. That is just me personally. Application of a surface preservative gel or compress of a bleaching solution before, during, or following arterial injection. Again, me personally, I will typically not put a bleach pack on the body while I am embalming it because I have other things I am focusing my attention on, and I don't want to run the risk, especially using a cautery chemical, of leaving it on there too long. Again, just me. Combination of surface and hypodermic treatments before or following arterial injection. And I am a big proponent of the combination after arterial injection. Now, skin lesions and ulcerations. Observe and evaluate any rashes, lesions, infected areas, decubitus ulcers, and skin cancers. After cleansing the body, the embalmer should begin treatment of these areas immediately to disinfect the affected area, preserve the tissue surrounding the lesion, dry the tissues, and deodorize the tissues. These areas should be of concern to the embalmer for the following reasons. Well, lesions don't happen by magic. They can be a source of contamination to the embalmer, such as staph and herpes infections. The tissues can be necrotic. Decomposition of the superficial and deep tissues is in progress. So you want to get that dead tissue gone and that area dried and those microorganisms dead. Blood supply to the necrotic tissue is poor. Little or no contact between arterial solution and the diseased tissue. Odors may be present. Tissues left untreated can produce offensive odors, may be noticeable after embalming, dressing, and casketing. And necrotic tissue can contain the anaerobic gas bacillus that produces gas gangrene. Treat the affected area with a topical disinfectant or swab with undiluted cavity fluid or a cautery chemical. Topically treat bandages or coverings before removal. Dispose of these materials in a regulated waste container. And treat the area hypodermically and apply saturated compresses or autopsy gel prior to embalming. Generally speaking, when I am working with skin lesions and ulcerations, not bed sores, not immediately, but stuff in visible areas, torso, arms, stuff like that, legs, etc., I will absolutely scrub it, clean it, put cotton on it, and then cover it with phenol solution. I'm going to burn it to death. I don't like using cavity fluid going out the gates because I don't know if I'm going to be standing in that room for an hour or an hour and a half doing a standard prep. So I would rather let the cautery chemical burn away and reduce the type of fumes I'm exposing myself to. And then when I am done embalming, I am done topically disinfecting and terminally disinfecting the body. Now I'm going to apply my preservative gels or cavity compresses and wrapping in plastic and being done with it. Again, my style of doing it. I'm not saying it's right. I'm just saying it's what I did. And believe it or not, people actually paid me at one point to do it. Apply fresh compresses after embalming. Dress the body in a suitable plastic garment. And when the hips or buttocks are infected, an adult incontinence brief can be used. Add absorbent and preservative powders to the garment or brief. Fancy way of saying, if you need to, and what most funeral homes do as a best practice, is they purchase adult diapers, Depends, etc., in a couple of different sizes, and then they use those on all of their cases, especially when they're dealing with something like a bed sore, and then on top of that, they will also use a plastic garment. Lacerations and fractures. Okay, a laceration is defined as a jagged tear in the skin. Lacerations are jagged. Incisions are smooth cuts. In the pre-embalming period, a laceration should be cleaned of any blood or debris. After the edges of the laceration are cleaned, the torn skin should be aligned. Several bridge sutures can be placed along the laceration to hold the edges in position during embalming. You're going to find most of these in trauma cases. If the laceration is in an area of the body that will be seen, massage cream can be placed around the area after the bridge sutures are in place. This protects the unaffected skin. So this is a fun thing. If the laceration is in an area of the body that will be seen, massage cream will be placed around the area after the bridge sutures are in place because it protects the unaffected skin. If you have lacerations as a result of trauma, chances are pretty good you're going to have some leakage from your arterial fluid. And if it has active dyes, which it's more than likely going to have because you're dealing with a trauma case, so you're going to be using your dyes as a tracer to see where your fluid is going, the last thing you probably want to do is have lots and lots of stain on the outside. Now, I'm not saying you're going to be tearing up the place with a low-level amount of cosmetic. I know you are. But get in the habit of putting this stuff on when you see it so that it's like, oh, I'm going to be using cosmetic. Get in the habit of doing it right. So that way you never forget on a smaller case or a less traumatic case and then cause a problem for yourself. So get in the habit of doing things right. For testing purposes, can be placed. but for practice and getting good at the game, will be placed. If the laceration is in a body area that will not be viewed, the laceration can be closed with a baseball suture. If it's in a visible area, you're likely going to be using a hidden suture or something of that nature. During embalming, arterial solution may leak from the laceration. Place a compress over the lacerated tissues to contain the solution as an effective means of surface preservation. You can do that as well. So you can apply massage cream to the external area so that nothing stains the tissue, and then take wet cotton and just slap it over the incision or the laceration. What that will do is apply pressure, and it's also not going to hurt the fact that the cotton is absorbent and it'll suck some of that stuff into it. Compound fractures pose risk of injury to the embalmer. Injuries to viewable areas do require restoration. Non-viewable injuries require containment, but do not need to be restored. And you can just imagine getting poked with that piece of bone. It is going to hurt. An abrasion, known also as an excoriation, is a wearing away of the upper layer of the skin as a result of friction. The embalmer encounters two types of abrasions. The first is a dry abrasion. Dry abrasions are dehydrated. The area resembles a scab formation. The tissue is dark and feels rough and firm to the touch. Dry abrasions do not present preservation issues because they're dehydrated. The area can be concealed after embalming. Moist abrasions are wet. They appear shiny. Preservation is necessary. The tissue is still vibrant. Cauterizing the wet tissue will dry the area for restoration and concealment. In the pre-embalming period, inspect and evaluate abrasions and clean the unaffected area. You want abrasions to dry and preserve. You want abrasions to dry and preserve. After embalming, the objective is to dry them. And how are you going to do it? You're going to force its way to that. So a hair dryer can be used to force dry wet tissue and expedite the process when there is inadequate time for chemical to work. Now, ideally, you can slap a surface compress on this and let it do its job. But if you picked it up at noon and it's viewing at 3, chances are pretty good you don't have that type of time available. So you're going to break out the hair dryer and let that do it for you. As a rule of thumb, if you need something dried yesterday, a hair dryer is what you're going to use to do that. Okay? Not a heat gun, a hair dryer. Pre-embalming treatment for skin slip, blisters, and scabs begins with application of a topical disinfectant. Do you see the moral of the story here? No matter what you get, whatever you're putting on your table, you are spraying it with a spray topical disinfectant. All loose and damaged skin is debrided. You must get rid of all the loose and damaged skin. Blisters and pustules are opened and drained. Apply a surface preservative gel or surface compress to the affected area. In visible areas, protect unaffected tissues by applying a light coating of massage cream. Allow surface treatments to remain in place during embalming. Arterial solution may seep through the affected areas. That's fine. After embalming, remove the surface chemicals and air or force dry the tissues. Dry areas will darken, and you're going to be using cosmetics whether you like it or not on these things. There are 3 sources of gas in a dead human body. When gases are present, tissues, distension, and swelling can occur. Gases can be palpated, touched, examined by touch, and what you will feel is crepitation, a crackling sensation produced by the presence of air in the subcutaneous tissues. This is really creepy the first time you feel it, by the way. Subcutaneous emphysema, the first type of gas we're going to talk about, subcutaneous emphysema, results from penetration or tearing into the pleural cavities or lung tissues. When gas is detected in the tissues and neither odor nor skin slip is present, examine the body for external punctures near the lungs, recent tracheostomy, or fracture of the clavicle, sternum, or ribs. Subcutaneous emphysema can be widespread in a body. Subcutaneous emphysema is a common condition after blunt force trauma to the chest and administration of cardiopulmonary resuscitation, or CPR. Moral of the story number 1. Subcutaneous emphysema, you have gas in the tissues. okay? But you do not have odor, and you do not have skin slip. You have gas with no smell, and it doesn't look like any of your tissue is falling apart. Decomposition. The 5 signs of decomposition: discoloration, odor, purge, skin slip, and gas. 1, 2, 3, 4, and 5. The 5 cardinal signs of decomposition: discoloration, odor, purge, skin slip, and gas. Gas can accumulate in the viscera, body cavities, or other tissues. True tissue gas. The source of this gas is Welch's bacillus, or Clostridium perfringens, an anaerobic, spore-forming bacillus that thrives on necrotic tissue. Tissue gas can be passed between bodies by contaminated cutting instruments. This is why you should always have 2 sets of instruments ready to go. A very strong odor of decomposition tissue is characteristic. These are the amines that are producing that smell. The condition may begin in the agonal and early postmortem periods. Tissue gas will accelerate until chemically arrested. Tissue distension may begin in the abdomen. Severe distension may restrict the flow of arterial solution and drainage of the blood. The abdomen should be punctured and the gas allowed to escape prior to embalming. You want to get the pressure off of the aorta so you're maximizing the amount of fluid that might get to the affected areas. Make a puncture with a scalpel near the standard point of trocar entry, 2 inches superior and 2 inches to the left of the umbilicus. Remember, this is anatomical left. Follow with the insertion of a trocar to relieve the tissue gas. When facial tissues in the upper chest are affected, make a semilunar incision from the center of the right clavicle to the center of the left to allow gases to escape, and embalm using restricted cervical injection. After embalming, channel tissues and apply pressure to the distended areas to force the removal of gases. Disinfect all instruments thoroughly after embalming and immerse the trocar in a cold chemical sterilant. Read the label of the product you are using and see what is the minimum contact time to be effective against C. perfringens. Ascites. When the abdomen is tightly distended, the embalmer must determine if the distension is caused by gases or edema. Either way, extravascular pressure is created and must be relieved before arterial embalming. Insertion of the trocar into the upper abdominal region will allow both edema and gases to escape. Generalized edema and tortuous or twisted veins visible in the superficial abdominal tissues is indicative of ascites. Edema within the abdominal cavities does not dilute the arterial solution but will dilute the cavity fluid. So what is happening here? Okay? What is happening here? It is a fluid buildup in the abdominal area. It is fluid above your intestines, not inside, but above. So when you are injecting your fluid via your incision, this fluid is not coming into contact with any of that. The moment you go to do cavity injection, now you're pouring your cavity fluid on top of this stuff. And therein lies the problem. You don't want to dilute cavity fluid, which is why we're going to aspirate as much of this edematous fluid out as possible and then put in our cavity fluid. And what we will likely have to do is then aspirate it again and reapply more cavity fluid because there is all this extra residual moisture. All right, folks, thank you for your attention, and we will see you next video.